Hi, I'm Dottie Deremo. I'm the Executive Emeritus of Hospice of Michigan, which means I'm long in the tooth and older than dirt. I'm going to be 68 this year, and I am 3 weeks retired after 15 years of the president and the CEO of Hospice of Michigan and the founding president and CEO of our national nonprofit advanced illness management company called At Home Support, which you are going to hear about right now. In my brief remarks, I'm going to do 4 things. First, I want to create a quick frame around the problem. Secondly, I want to talk about how it takes 14 years to become an overnight success in terms of our at-home support program that is improving quality outcomes for patients, supporting stressed caregivers, and saving 30% net total health care costs. This program was built on 14 years of evidence-based outcomes research that is still ongoing. I'm going to talk about the program's successes and the final thing is some very unique features of the program. As I listened today, I was reminded of a haiku that goes something like this: "Problems worthy of attack prove their worth by attacking back." And nothing that is easy, is worth really accomplishing. What we're trying to do is really change a culture in this country that is well embedded. Let me take the frame. We know that 80% of the cost of Medicare is from chronic disease. We know also that if you look at a pyramid, the 5% of that population, Medicare population, accounts for 50% of the entire Medicare cost. But that is a very special population. When you have end-stage disease and a median lifespan of 24 months, you will have predictable crises at unpredictable times. They will not be Monday through Friday from 8 to 5:30. They will be Sunday morning at 3 o'clock. And currently, the backup system for care for these individuals and their stressed caregivers is the emergency room, the frequent flyers, the emergency room, the hospital, the rehab unit, home care for a brief period of time, and that cycle will repeat 2 to 10 times in about 18 months before these patients are even eligible for hospice. If they get into hospice, the median length of stay is 7 days or less, with 40% of those patients being dead within 48 hours of being signed onto the program. We are not doing end-of-life care. We are doing brink-of-death care. This is unsustainable cost, but the biggest frame is this is unconscionable suffering. The at-home support program, now this is part 2, has been developed with laser focus on this 5% population that are not eligible for hospice or do not want hospice. There are 4 synergistic components to the model and the program. First is a 24/7 delivery model that is specifically designed for this patient population. You can focus on compliance for Mabel with her end-stage congestive heart failure, and she can take all her medications, and she is still going to have a predictable care crisis at an unpredictable time. Having Monday through Friday or just a call center is not enough. You have to have 24/7 availability. So that's the center, the delivery model. And it is an interdisciplinary model. It is very cost effective, but supporting that delivery model is some very sophisticated components. At-home analytics. We have created our own predictive modeling software. We can go into a payer, Medicare Advantage plan, accountable care organization, mine their raw Medicare claims data for patient identification to find that 5% of patients that will account for 50% of the cost. So patient identification comes through the predictive modeling, and they're automatically then, based on contract with the payer, eligible for our program. We also have a cloud architecture, web-based electronic medical record system that has outcomes built into that electronic medical record system. And we are able to currently track both quality and cost outcomes for patients, for caregivers, and for the payer. A third component is a telesupport center, a 24/7 call center that has specially trained registered nurses. When Sam, Mabel's 87-year-old husband, is calling in because Mabel cannot breathe, he has one number to call, ease of access. There is one number to call 24/7. That nurse has two computer screens. One has the medication administration record. The second has the electronic medical record. That nurse knows exactly what has happened to that patient that day and can many times triage. The final thing is, in case Mabel does hit the emergency room, for the networks that we are covering for our payers, we have at-home transitions. We have coaches that we have trained that are embedded in the emergency room in the hospital, so that if Mabel does hit the emergency room, we are able to coordinate care and help to minimize care that might happen because there's not the information on the patient. So those are the four components. Let me now talk quickly about the successes. I'll give you one example. The Detroit Medical Center Pioneer Accountable Care Organization, which we took our first patient last April 26th, and in 8 months, we had 270 patients enrolled, an average daily census of 150 patients for 8 months. We decreased admissions from the base period, the previous 12-month base period, by 33%. We decreased hospital readmissions by 57%. We've decreased ER utilization. The most recent figures are 20%. And then when you actually look at the kinds of calls that we took in, 37% of the time we were able to prevent emergency room use. And the overall satisfaction score for patients and families is 4.86 on a 1 to 5 scale. Finally, on an average daily census of 150 patients for 8 months, we saved $3.5 million. That's net savings. Net savings. That was 4% of the entire national savings of the Pioneer Accountable Care demonstration project across the country. That's on a average daily census of 150 patients for 8 months. We're very proud of that. Some unique features, now I am in part 3, is that this model is plug and play. As soon as we have a contract, we are able to mine raw claims data within 2 weeks, and we have trained staff to begin to take care of patients. Another unique feature is how we get paid is on a percent of the savings. We don't do a per member per month. We don't do a fee for service. We are 100% at risk for quality and cost outcomes. That is very different than the hospice and the palliative care world. A third unique feature is that we have now created a franchise-like partnership contract model so that we can rapidly spread this program across the country. We own all the intellectual property. We are able to do all the predictive modeling, and we are able to also provide the telesupport. But we train the local provider on following the model. It's like McDonald's. If you cook the hamburger, you have a McDonald's franchise, you have to follow how the hamburger is cooked. In closing, the final unique features is ease of access, open 24/7, and we focus on the forgotten variable, that stressed caregiver. Thank you.